PVD, or peripheral vascular disease, is also known as PAD, or peripheral arterial disease, and that really is just a deposition of plaque or cholesterol deposits in the peripheral vasculature, meaning the blood vessels going to the arms, the legs, or the neck or the brain. Signs and symptoms of PVD include heaviness in the leg. For instance, if a patient has a blocked artery in the leg, in the thigh, or in the calf, or in the pelvis, their leg may feel heavy or may feel tired when they walk. In addition, patients can develop ulcers or wounds in their legs that don't heal because they don't have enough blood supply to their leg. If a patient develops PVD in their brain or in the arteries going to their neck, they may have a stroke or mini-stroke symptoms such as numbness in an extremity, weakness, or problems with speech. Claudication is a very important term, and that's simply the medical term that's used to describe pain in the patient's legs when they walk. This can be of varying degrees, and some patients don't describe it as a pain. Sometimes they describe it as a heaviness or aching in their leg when they walk, and that just simply means that the blood supply to the leg is not adequate. In some patients, claudication can progress to the point where they're experiencing pain at rest, or in the worst case scenario, they can develop a wound, an ulcer, or gangrene in that leg. PVD is diagnosed really by your primary care physician. If the physician has a suspicion of more advanced PAD or PVD, then we can do special ultrasounds of the arteries in the legs where we measure the blood supply, sometimes with just a simple test using a blood pressure cuff. In more advanced circumstances, we need to sometimes put catheters in to shoot dye or do a CAT scan or MRI to look at the blood supply in the legs or in the neck. The consequences associated with PAD can be quite severe. If left untreated and if it progresses, we can see what we call critical limb ischemia in the legs, and that just simply means that the patient has not enough blood supply in their legs to heal up a wound or ulcer on their foot. This can often lead to an amputation not just of their foot but of their whole leg. In addition, PAD in the head or neck within the carotid arteries can often lead to stroke if untreated or undiagnosed. It's very important for a patient to see a cardiologist or vascular specialist for PAD because early treatment is very, very important. In addition to sometimes removing or treating the plaque, it's often very important to lower the blood pressure, lower the cholesterol, and get patients to stop smoking and make sure they have the appropriate measures so the disease does not progress. The team approach for PVD at St. Francis is very unique, and I think it really gives us an advantage and really gives the patients the best treatment possible. We work with the cardiothoracic and vascular surgeons as a team to come up with the best treatment necessary, whether that can be done with a simple catheter with no incision or with open surgery. In many instances, we can just treat them in the office with medications or other appropriate measures. We're very lucky at St. Francis to have several new technologies with PAD. Those include a laser where we actually vaporize the plaque from the leg from just a small puncture in the groin. We also have a drill that we use to actually modify and remove the plaque and grind it into fine particles so the body can take it up. And finally, we have a plaque excision device where we shave the inside walls of the arteries. We've been using these approaches to treat peripheral vascular disease in the legs and have been very successful with their outcomes and have been able to save quite a number of patients' limbs. In addition, we're very aggressive with not only doing surgery on blockages within the neck, but actually just going in and ballooning and stenting open blockages within the carotid arteries. And the less invasive techniques using catheters and lasers and other technologies such as balloons and stents seem to be comparable or even more efficacious than surgery. We have a very collaborative approach here at St. Francis. We also have been very successful in providing networking with podiatrists and wound care centers. For instance, one of our measures has been providing non-invasive screening within these offices so we can pick up the disease earlier in the process. That way we can see these patients very early on and apply treatment in less invasive forms before it becomes a very critical problem.